Okay, so we could talk about, let's try to break down the terms so y'all kind of have a general overview of how this is kind of going to go down. So FTM is, first of all, it seems like it's all over the place. I was reviewing this stuff last night and it just really brought back memories of how you're getting stuff from pharmacology, from biochem, from histology, and it seems like a jumble. But understand that they're trying to build a framework for you so that when you get into the more of the clinical aspects, you're prepared for it. So we get it. We were there. We know that it seems like it's all over the place, and it's hard to study one subject when you're getting 10 subjects at a time. So understand that, first of all. Secondly, the way FTM goes is it's a lot about buzzwords. Okay, so as you go forward, when we get into cardio and pulmonary and renal, it's very much conceptual. The physiology behind it and the disease processes, they're very much a stepwise thought process. But we'll get there when we get there. For right now, we're going to focus a lot on the big buzzwords. Like you'll have, I'm sure y'all have heard that the tests are built on clinical vignettes, right? So let's say a blah, blah, blah year old patient comes in with blah, blah, blah. What are you going to give them, right? So for right now, you'll get those vignettes, but you don't have enough detail in your learning at SU at least to really break it down into steps. So you'll see in the questions, there's a lot of buzzwords that'll clue you into the answer. So that's what we're going to focus on. We're going to do a lot of the things that we felt were important that'll clue you in. Like if you see this certain subset that they give you, you can instantly say, okay, this is Marfan's disease, or, but we don't want to get too far ahead of ourselves. Let me go ahead and share my screen. What I'm going to do, I'm going to go through the week's material. We'll do some interactive questions. I'll use the questions as like a teaching process. And then Lindsey's going to do like a hardcore question session at the end. With that being said, it also should be noted that the best correlation to how well you do is how many practice questions you do. And the thing is, when you make your schedule, typically the questions go at the end because you want to get through everything first, so they get left off. But even if you need to do practice questions beforehand, like not necessarily knowing all the material, you can learn from getting those questions wrong, right? You can say, why is this one right? Why are the rest of them wrong? But
I would argue that getting them wrong is a better learning tool than getting them right.
For sure. And understand that there is an art to doing these style of questions. It's not just, do you know the material? It's how well can you do this multiple choice thing? There are never going to be A and B or all of the above. The strategy behind crossing stuff out and seeing like maybe two answers are very similar, those are automatically out because it can't be two answers. You get faster at doing this. That helps your stress on the test. So you need to get into a routine of how you do this stuff. When Lindsey and I take tests, it's the same thing every time. I have my methodology in my head. I highlight, I go through it once, I flag what I need, I go back, I check the flags, and then I check it all again. It's always the same process that eliminates the stress. You want to do things in a methodical manner. So anyway, that being said, these reviews are going to be highly question-based because we want to kind of stimulate that idea of, can you take the information they're giving you and answer the questions based on it in this style of format? Okay, now that's enough talk about that. I hope everybody was able to go get the slides. Go ahead,
just to let you guys know, I am monitoring the chat. Feel free to ask questions. Feel free to talk to each other in the chat. Like you guys, your peers are also a really good resource. Brady and I have talked about your upper termers are really good resources. You know, I made a post that, you know, reach out to DES, reach out to your professors, but you guys are resources for each other. Don't forget that. Like figuring it out with a friend that's going through it with you is also a really good thing. So feel free to talk in the chat. Feel free to ask questions of us in the chat. But that's a really good thing.
That is a good point Lindsey made, because misery loves company, if you want to say it that way. It's sad right now that you have to do this online. But if you can find, if it's your small group, I guess y'all did get into small groups last week, I guess. Make a group chat, meet a few people if it's through Facebook or whatever, because group studying helps with your motivation. We try to do it. We all have group chats, multiple group chats that we discuss stuff with. But the sooner you can meet people, the easier it'll be to kind of go through this together. I think that's all of the housekeeping stuff. All right, again, you can find my slides on the Scrubs page if you need them, and we will get started. All right, so I run Scrubs. You can find all my reviews there. Also, we did term 1 reviews last term. So all of my, the older posts have my old reviews in there. So if you want to get ahead, you could look at those. Lindsey runs Dog Mom. She's very good about doing questions. She'll do questions of the days for y'all. So look out for that. And she's very responsive on getting back to people when they have questions and stuff. We try to get back as soon as we can if y'all do message us or whatever. Obviously we're in class too, but we'll do our best. You can look in the additional resources. This is a good resource for you. We put stuff that we found helpful on our Google Drives in the additional resources folder. So old questions, if you're looking for more questions, some diagrams people made, some tables. So use whatever you find helpful. As for making a schedule, these are just a few things that I wanted to put in to help you get going. So try not to fall behind, okay? So like there's no extra days before the test. It's every 3 weeks. So my goal when I study is by the Monday of the next week, everything from the previous week is done. I don't like going into Monday having to feel like I have stuff from last week. So all my post reads are done. All the questions for that week are done. So I like to start a new week fresh. That way there's no carryover, because if you're behind and when you get to week 3, you tend to lag on the week 3 stuff because you're worried about the old stuff. So do your best to not fall behind, but that's very much easier said than done. I'm not a big pre-reader, but if you like to pre-read stuff, keep it minimal, because what you'll find in lectures is sometimes you'll spend a long time memorizing when you pre-read and the teacher just glosses over the slide. Like what you want to listen for in lectures, what does this teacher find important? Doesn't matter what you feel is relevant. It's what they sit there on the slide. Like Dr. Impadya, when you get her, like you'll notice when she starts teaching, she'll stay on a slide for like 10 minutes. And like you just put a star at the top of the slide because there will be a test question from that slide. So you want to listen to different teachers and listen to how they organize their lectures. The DLAs, y'all know by now, are stressful, but you need to treat them like a lecture. There can be just as many questions from a DLA as from a lecture. So keep that in mind. When you go through practice questions, use the IMCQs and the ExamSoft quizzes as a reference for how that teacher is going to frame their questions. So if you see it on one of those quizzes, you can say that's a pretty valid test question. And we've had some quizzes where they were like blatantly difficult just to like push us into studying. But for the most part, those are representative of how the tests are going to be. Sakai, they always post weekly questions on there for you to practice. I would do those. And then as for other resources, I think the best thing to do is just ask upper termers what they use. Sometimes there are old quiz packets and old question packets that are passed around. Like I said, Lindsey and I both put it on our drive, whatever we had, so you can ask around. Neither Lindsey and I are big on Anki, but some people swear by it. It's the idea of doing flashcards, it's spaced repetition. So if you like that, I know term 2, one of our friends, Kishore, he's big on it. So if y'all know Kishore, he may be a good person to reach out to and to talk about that, but it's foreign language to me. I don't like doing it. So, and then the big star right here is first aid. Go buy yourself first aid. It is the Bible that we use. It is the prep book for the boards, right? For the step 1. So if you're not familiar with it, go get it. It's the first book I always open when I have a question, like when I'm worried about something. So yeah, as for, I guess a good question. So as for annotating first aid, it's kind of like an annotated book already, right? So if you're wanting details, first aid's not going to be the book to find about details, explaining stuff, but it's going to have everything that's high yield for you. So if you're looking for a table just to break down hormones or something, or a nice graph, or if you just want to know from this lecture, if I look in first aid, what is relevant? Because it seems like it's all over the place. If it's in first aid, it's relevant. So like for different modules, like I'll just pull out the pages I like on the PDF for that specific topic. And what's up, Lynn? Oh, you got it.
So I have a couple questions in the chat, and I just want to touch on them real quick with you guys. Honestly, I used First Aid 2017.
Yeah, it doesn't matter.
It doesn't really change year to year. And so if you have a book already, and especially 2020 to 2021, I would not I wouldn't invest in a new one. Some good post reading strategies. I think this is really good to talk about. So post reading, I've talked about this before. You guys all know my favorite way to post read is whiteboarding. Honestly, so the standard is about an hour and a half per lecture for a post read. So you need to post read in a way that helps you actively recall. And Brady talked about going through the slides, making sure you understand the concepts, and then going back and filling in the details later. So you can do that by mapping it out. I like to do it on the whiteboard. You can do it on notes, and organizing in a way that your brain understands it. Like really, it's just about sitting there in repetition or writing through it. I also wanted to touch on the eSoft quizzes real quick. A lot of people are going to freak out this weekend after their eSoft quiz because they're not going to do well and they're going to think they're going to fail the term. That's not true. And here is why. You aren't going to prepare for an eSoft quiz like you would for an actual exam. And so right there, you aren't going to be in the mindset of a test. And so if you get a 40, 50, 60 on this eSoft quiz, it doesn't mean you're going to fail the actual exam. So just keep that in mind. Also, some of these questions, you want to practice harder than you play, right? And so some of these eSoft questions will be at a level that feel harder. You are going to have hard questions on your exam. I'm not saying that this is completely unrelated to the exam, but make sure that you just understand these eSoft quizzes are kind of letting you test where you are and test the system for taking the test, and also showing you how this information is going to be tested. So please, 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 if you do not do well on your eSoft quiz this weekend, do not panic and think that it means you're going to fail the exam. Just look at the report they give you, because the eSoft quizzes, they will give you the questions and explanations afterwards. That's the only time they're going to give you those explanations, FYI, is the eSoft quizzes. But just look at that, see the objectives where you don't know, and move on from there.
And yeah, so like the idea is that even get it wrong, as long as you look at it afterwards and understand why you got it wrong, then it's a learning experience. So take it like that. My eSoft average was always significantly lower than my actual test averages. So don't stress about that. Lindsey did mention something that I had said in the advice session. I'll just elaborate on that. So this is how I post read. My first post read is all about conceptualizing it. I'm not focused on memorizing. I find this less stressful. So by the time I finish my first post read, my goal is that I could put up the slides and I can explain it to somebody. I'm maybe not able to cover my eyes and fill in the small details, but I can put it up and I can put it in my own words. That's the goal of my first post read. The second time I go through, then I'm worried about memorization. Then I'm worried about ironing out the small details and the fine points. So my goal is that I find it less stressful when I go through the first time, not having to stop and memorize for an hour, one page or whatever, or one little concept. And then by the time I start memorizing, it's not stressful because I already have a basis of understanding. So that's how I do it. But understand this, you got to figure it out for yourself. You take advice from all of us, from all the upper termers, and you make it work for you. Much of med school is just learning how you learn, because everybody's different. So if it's not working, mix it up, figure it out, and you'll be fine. All right, so again, yeah, look at first aid. At first, when you look at it, it's kind of foreign, but you get used to it. You just have to find the little section that works for you. We use the PDF, so then you could just search it, and you could find the information you're looking for. You don't have to thumb through the book. Okay, so for the test taking strategies, you should go into doing practice questions the same way. So the biggest pitfall for people is the clock, right? So you only get 72 seconds per question. I try to keep myself at a minute. If I can do the question in a minute, then I have time to go back and check my questions after the test. So try to do it in about a minute. There are different functions, the highlight, the strikeout function, use them. Also, you can mark the answer. So when you do these eSoft quizzes, that's the same platform that you take the tests on. So start using it, highlight as you go, cross them out, mark the questions you're not sure about, and that'll help you, get into a pattern of how you want to do it correctly. So you won't have a whiteboard. That's just this online thing. We just don't have them. So the teachers are aware of that. So as for complex math problems or like filling out pedigrees, they understand. So they've worked with us through this process. And then my goal is that I never actually change an answer unless I'm sure it's wrong. I find that if I do change an answer, I tend to change it from right to wrong. So my goal is my first answer stays unless I'm like, oh man, I see my mistake, right? Because that's the worst when you change something from correct to incorrect. All right, as for testable material, and you'll get better at noticing this in the slides and stuff, but note differences, right? So they'll say like 3 pathways go this way and 1 goes the other way, right? To highlight the one that's the one, right? Because when you have A through E and they have to select one, they're going to select these differences, these variances, these things that you're like, why does this do this and everything else does that, right? You want to focus on those weird things that go on. Also, again, I mentioned that what the professors emphasize in lecture, and by all means, stuff that's clinically relevant. These test questions they have to ask, or that they ask, have to include some sort of clinical scenario. That's the whole goal, because that's how the boards are set up. So a good training tool you can use is find the disease, right? Any disease they mention, and work backwards, right? They'll have Marfan's disease, and then you'll say, okay, that's a collagen problem, right? And then you work backwards and say, okay, these are the symptoms of it. These are, the pathogenesis of it, and this is the problem. So make sure you focus on the diseases, because that's a good reference of how what exactly is high yield. And then practice questions. Yeah, let's see. Okay. Yeah, we mentioned this, right? So again, this is all posted, y'all could read it. But yeah, there's no right way to answering questions, so figure out what works for you. Just try stuff out, and you'll be fine. All right, let's start with a question. How do you want to do this, Lindsey? You think they should private message us like we've been doing?
Yeah, so when
Okay.
you're answering questions, go ahead and private Brady or myself so that everyone gets a chance to think about the answer and it's not just going off of other people's answers. We really want you guys to learn this material.
And again, don't stress out. A lot of these are just like FTM type stuff. Like, it seems like, why would they test on this? Well, it's just for FTM. Once we get into the more medical based stuff, it's a lot more clinical. But these are just a lot of things that we've seen tested previously, hint, hint. So maybe it would be important for you to know it, right? All right. All right, so this one's pretty quick. We'll try to get through these. Lindsey's going to have it set up at the end with, it's more of like a test style, but I'm going to do these in more of a teaching format. Okay, so cilia is going to be 9+2 arrangement, whereas the primary cilia, or the base, is more of a 9+0 arrangement. And you could see that here. So I would make a star by this little picture right here, this little electron micrograph. So it's 9 doublets plus 2 singlets in the middle, and that is the arrangement here. So and you could see the cilia is basically used as, like in the respiratory tract, it's a unilateral cilia, so it'll help move the mucus up from the respiratory tract up, and so you can cough it out. But you can see here it has this 9+2 arrangement, but when you get down to the base, the primary cilia, it has this 9+0, and you can see that here. So this is just one of the things we saw tested. Here you go, look, you can see this 9 triplets, right? So you can see the difference here. The cilia here has this 2 singlets in the middle, and the primary cilia, or the base, has this 9 triplets. All right, let's try this one. Yeah, so these are a little bit more just, they're not exactly vignette style, but I just want to point out some of the things that you should be referencing when you look at the lectures.
So I have a few people asking how they're going to do the vignette style for all of the very FTM like stuff.
Okay, so like,
It,
for this, they could say a 26-year-old woman comes in and she's having problems with with her breathing, or she's having mucus buildup, or some sort of pulmonary problem, and then they could just go straight at it and say which of the following pairs does this, right? So for FTM it will be a vignette, but they're asking you these buzzword type questions, and so just bear with it right now, because once you move along in the term, there'll be like proper vignettes. So it'll give you an actual patient, and then it'll give you like a buzzword in the second half of it. So it'll work out like that. They could say, so an older patient comes in for further testing on heart trouble or neurological trouble, and then they could just say this: which of the following is true about these inclusions? So these inclusions are lipofusion granules, so they're a wear and tear pigment, so they develop over age, right? And then hemosiderin, these are just some of the little things that that were mentioned in your notes right now, is more of like an iron storing. Melanin is made in your skin. It helps with your pigmentation. So yeah, and again, a lot of this stuff that you're touching on now, you will see again and again and again. So you're just getting your feet wet through this process. This image is very high yield for whatever reason. It's one of those things, I just see it in my sleep and I know what it is. So cool. So we're looking at these little things right here, right? So oh, wait, nope, that's not right. Sorry, it should be pinocytosis. Yeah, let me, I'll fix that on the slide. This is the correct answer. I don't know what happened there. So yeah, you're looking at this. So pinocytosis literally means cell drinking, right? So when it brings in fluid, it's cell drinking. Make a note on your slides that this is pinocytosis. Okay. Okay, cholesterol. So as a physician, you're worried about your patient's cholesterol levels. He comes in with chest pains. Increasing the amount of cholesterol in the plasma will have what overall effect, right? So they will put it, for right now, they will put it in this vignette format. But you're looking for buzzwords. All right, so remember that cholesterol is this big globule, right, that you're putting in the plasma membrane. The plasma membrane is very fluid, right? It's got like the phospholipid bilayer. The lipid part is in the middle. The polar parts are at the end. That's because the polar parts are around the water, and you want the lipid in the middle. So when you put these big sections of cholesterol in there, what it's actually going to do, it's going to decrease the fluidity, and by doing that, it basically just stiffens the membrane, and it'll decrease the permeability. Obviously, being stiff, stuff can't get in as well. So some of the functions of cholesterol, you could just make a note of this, but again, this is going to get into this in so much more detail. It is a precursor of the steroid hormones that you'll see in the adrenal gland. It's a process for bile acids and bile salts, and then the plasma membrane. So this is the slide that I would say is important. Overall, it'll decrease the fluidity. And I did put a slide in here for completeness sake, because it does vary with temperature, but for all intents and purposes, you should know this, that it's going to decrease this fluidity in the membrane, right? And then you can go through this on your own if you want to, but I think the most important part is under normal circumstances, it will decrease the fluidity and the permeability of the membrane. All right, so this is a more vignette style question. All right, very good. That's my dog snoring in the background if you hear. I'm sorry about that. All right, so screening tests. So let's talk about this. What's going on? Okay, she's 2. She's very young. Always take note of the age, right? So parents bring her in. She has this upper respiratory infection. Okay, we can't really say much for that. She's kind of small for her age. And then this is kind of one of those standout things like, why are you telling me about this, right? Because it's important. Okay, so what screening tests would you look for? Well, what happens in these patients with cystic fibrosis, I should have asked what she has, but she has cystic fibrosis, right? So you'll see cystic fibrosis is brought up time and time again. It's one of those things they like to test on because you could test it in so many different variations. It's physiologically, whatever. So you can test it in so many. So what they do is this cystic fibrosis transmembrane receptor, CFTR receptor, when it's made, the protein folds incorrectly. So the receptor or the membrane, the transporter in the membrane cannot, it doesn't transport chloride as well, right? So what happens is these patients have a buildup of chloride intracellularly. The only difference is in the skin, these channels are flipped. They're called ABC transporters. It's very unique. I don't know if it's unique in the body, but for us, these AB transporters are only really talked about in cystic fibrosis. So what happens is this chloride can't get across. And if you remember that since it's on the skin, it can't get across. What that you can actually do is take a sweat test, right? So they have salty skin. Sometimes the parents will say that when they kiss them on the cheek that their skin tastes salty. So this is going to cause a constellation of problems because with that chloride, you're going to have a lot of water that builds up. And so, or water that can't get through the membrane like the chloride. So with that being said, a lot of mucus builds up. This is why she has a upper respiratory infection. And a lot of the pancreatic enzymes that are made can't get through because with that mucus buildup in the pancreas, they won't get through the bile duct. And this is why, so you can't get, I don't want to go too far because y'all haven't really covered it yet, but this is why you get these foul smelling stools because a lot of the enzymes aren't there. So I know y'all literally just touched on this, but this is just an introduction. So the screening test is going to be something, it may not be completely diagnostic, but it's saying, okay, it's a high probability this is happening, right? So after this, you could get PCR or something like that to try to definitively diagnose it. Okay, so yeah, and this is kind of as far as y'all got right now. So a deficiency in this transmembrane receptor, the salty skin, and just remember, if you can't get chloride through the channels, you can't get water through either, right? So with that, a lot of these things have to do with mucus buildup. These patients, it's very, even at a young age, like they have to wear these vests that kind of pulsate their back to help break up the mucus, to help them cough it up, just because this mucus that builds up in their lungs is going to cause a lot of problems and be a conduit for infections. All right, let's try this one. All right, very good. So when in doubt, go with the longest answer, right? So respiratory distress syndrome, typically these children they're born prematurely. So what happens about the 20 to 26 week mark is you start building surfactant, and you'll get into this in pulmonary. I just want to touch on it. But one of the most important components of the surfactant is this DPPC. But y'all did talk about phosphatidylcholine. So this is one of the really important markers they like to test on this stuff. So this is going to help keep the alveoli or the lung sacs open. Okay, it's going to decrease the surface tension of the alveoli in the lungs. So it'll allow the lungs to stay open and the child to breathe properly. So if you have a premature child, what'll happen is they're not building surfactant, and one of the complications is they could have respiratory distress syndrome. So we'll leave it at that for now. Right, and so you can see the surfactant molecules, that's these little yellow ones here. So it'll actually, it counteracts tension, so it'll prevent this alveolus from collapsing, this blue part from collapsing inward. All right, and then I know that was an awful, or I guess it was a DLA, that lipids DLA that y'all had to do. It was rough. Let me show y'all a trick. This one actually helps me out. So as for essential amino acids, you really want to remember linolenic and linoleic acid. So if you look at it, so linoleic acid is omega-6. If you work backwards, the N is the sixth the sixth digit, or the sixth position. That's it. The sixth letter. It's a letter, actually, not a number. From that, right? So it's 6. So it's omega-6. Here, the N is the third, right? So that's the only reason I ever remember it from the back. So remember those, because they can ask you, you need essential amino acids. They could give you a list. Which one of these is omega-3, right? Okay. As for that, like, what do you need to know from that lipids lecture? Keep it, like, find the things that are stand out to you, right? What they feel is important. Something like for instance, the surfactant, right? That's something that stands out. So they could ask about that. They don't tend to ask some random variable in the corner of the page, right? It tends to be something that is relevant to clinically. Okay, and then this kind of breaks it down. I like these because it kind of gives me an overall picture of like where stuff goes, right? But like if I looked at this, one of the first things I would say is sphingomyelin is the only thing in this category, right? So is it important? And come to find out, it really is important when you make the myelin in the nerves. So yeah, so that's something that stands out. And then we talked about phosphatidylcholine. That's that part of the DPPC that's used in the respiratory tract. All right, let's get into some of this math stuff that nobody likes. I had to relearn this last night. I was not happy. So let's try to do this. Now, if you need to, you can use scratch paper, but keep in mind on the exams, you won't have it. So we're gonna work it out together in a second. All right. So I'll say first off, this is a very FTM style question. Once you get to term 2, you literally do not care about this at all anymore. So one of the first tricks you need to do is, if you ever have it in millimolar, you need to divide it in half, right? So you would have 150 of sodium and 150 of chloride, right? So that'll be a total of 300. So always be mindful of that, because that's going to matter. You have to do the same thing here with the potassium chloride. Okay, I think the next slide outlines it. Okay, yeah, it was A, but let's go through it. Okay, first thing you're going to do is osmolarity. Okay, this includes everything. So in red, it's everything. So if we annotate this, so we already broke up the sodium and the chloride, right? So in compartment A, you're going to have a total of 600, okay? Compartment B, you're going to have 300. Because remember, we had to split the sodium chloride, we had to split the potassium chloride. So the thing about osmolarity and it being everything is that you're worried about what happens transiently or what happens in the immediate future. So the point here is, wherever there are more particles or more things in solution, water's going to go to that side, okay? So you can say that A is hyperosmotic. When you look at osmotic or tonic, you can think of particles, right? It has more particles, like tonic. When you drink a gin and tonic, it's like water with particles in it. for lack of a better term. Right, so think of it like that. So it has more particles, so then water is going to go towards the side, right? Now, this is going to happen transiently because what you're going to see is over time, the urea is one of those things that can cross over. Okay, so first we do osmolarity, and this is what we get, right? So you'll know that it's A is hyperosmotic, it has more particles compared to B. So if we said, I mean, these are compartments, but if we said B was a cell, we would say that the cell would shrink, right? Because the water is going out of the cell. Okay, now, over time, this is gonna cross over, right? These are common things that cross over. So basically, things that are charged are not gonna cross, whether it be a membrane or a cell. So you're not worried about that. These are sort of things that are gonna cross. So what you'll see now is we have 450 on each side, right? So transiently, water is going to move to compartment A, but over time, once that urea crosses over, it's isotonic, right? Because this is what we're doing. We're worried about everything that doesn't cross, right? Because anything that crosses is going to be at equilibrium over time. So you're not worried about it. Urea is going to cross, it'll equal out. So you're only worried about these other things. So you could say 450 with the urea, or you could just not even think about the urea, and you could say there's 300 on each side. Maybe that's an easier way to go about it. So don't worry about the things that cross. For tonicity, you're only worried about the things that don't cross. So you can see that they're equal. So if B was a cell, no water flux, right? It wouldn't go in or out, it wouldn't cell. So if you had to put this on the exam, if they said, B was the cell, right? If they said that, and this is the extracellular fluid, you would say transiently the cell would shrink because water would be moving out, but over time it would return to its original position. Right, I hope that makes sense, because over time when this urea crosses, the water is going to cross over too. Okay, so you would say transiently the cell would shrink, assuming it was B, and then over time as the urea crosses over, it will go back to its original position. So I think the key here is just to make sure you do it in order. Make sure you do osmolarity first with everything, and then you go into the tonicity, the stuff that doesn't cross. And this is one of those things you kind of just have to practice with. I'll put this in here for completeness sake. I don't know if you'll really get into it, but equilibrium or isotonic fluid is 0.9% saline. So you get half saline, that's basically more water than saline, right? Because it's less particles in it. But all right, let's go into this with action potential. If for right now, if y'all have questions on this, it may be better to send them to Lindsey right now, because it's hard for me to follow the chat when I'm talking.
Just real quick for the percentages for the saline, unless they specifically talk about a certain one, I wouldn't memorize that list right now. So don't stress about that saline list. I think they tested us on one of them in maybe term 2. No, CPR2, because they talk about volume expansion.
Yeah, but actually, they use dextrose, but they still told you it was a hypotonic solution. Don't stress, just maybe know that 0.9% of sodium is what your body's at. So we have salt water in our bodies, basically, it's 0.9%. If you give less than that, you're basically giving more fluid, right? It'd be hypoosmotic. Okay, there was a few questions. Yeah, the urea will eventually cross over. So once it crosses over, it'll be at equilibrium and you won't have to worry about it. So when you say transiently, that's like that immediate response when you drop the cell into the fluid. All right, so you're gonna get into this a lot more in cardio and neuro in term 2. But what you'll see is the action potential here. So the sodium channels start opening, right? So your membrane potential is going to be at -70. That's where the cell likes to sit, right? So you have sodium on the outside, you have potassium on the inside. Those are the main players. So due to the ratios there and the amount of channels you have, the cell is going to want to sit right around -70. So what you'll see is that anything that's going to bring it positive, right, is going to be sodium going into the cell because sodium stays outside. Okay, so what's going to happen here is the sodium channels are going to start to open, and then it's going to hit this threshold point, and then sodium is going to start flooding into the cell, right? So this is sodium jumping up, right? And at this point, the sodium channels are going to start to close, and potassium channels are going to go in. So at point B, you have these sodium channels, and from extracellular fluid, the sodium's rushing into the cell. And then at this point, about +40, the sodium channels start to close. Potassium, which is primarily inside the cell, those channels are going to open and the potassium is going to shoot out. And its goal is to bring it back down to resting membrane potential. Okay, so B is where you're going to see the sodium influx, and C is where you're going to see the potassium efflux. All right, and you can see that here. We kind of talked about this. So, right, sodium, potassium, there is this little after hyperpolarization phase. You don't really need to worry about that too much right now. And then here it has it at about -60, but we'll talk about it in a second. Oh, well, here then, yeah. All right, try this one.
Hey, Brady, we have a lot of questions for the previous
Okay.
MCQ that you just did.
Okay, we'll give people a chance for this and then we'll go back. Okay, so if you remember, I know this was a difficult lecture. If you remember the driving force equation, actually I have it on the next slide. I'll put it on there. So RTF is your Nernst equation. I don't even know if that's in the notes, but I actually took this from an IMCQ, but that represents the Nernst equation. So this driving force is the membrane voltage minus the what is it called? The electrical membrane potential. Is that it for sodium? Membrane voltage minus, I forget what it's called for a second.
It's the equilibrium potential.
Equilibrium potential, that's it. Okay, so what you'll see here is on the next slide, you could memorize which correlates to what, but for sodium, this Nernst equation is going to be a +60. And you could see that the potential of the cells is at -60. So if you use this driving force equation, you get 120 millivolts of influx. So what helps me out, some people have tricks to memorize. I look at it there, right? So some people have tricks, so opposites attract. So if you have a positive driving force and a positive cation like sodium, they're going to repel, right? So they're not going to go together. If you have a positive driving force and an anion like chloride, they're going to go together. So that's a trick people use. For me, I actually just remember like sodium's always on the outside, right? Primarily when we talk about this in humans. So sodium's always going to rush into the cell. So I use it like that. We're talking about sodium, it's going to go into the cell. If we were talking about potassium, it would probably be efflux, right? But if you like this, people seem to like this. And so opposites attract. But if you use this driving force equation, is the equation flipped? Is that what people are saying? This was actually straight out of an IMCQ. Oh, you know what it did? Okay,
No?
I'm sorry. Nope. This is what I did. I put this in here after last night. It should be actually negative 120. But I should have explained this. Negative 120 is the same thing as saying positive 120 of influx. Right, so it actually does work out to, this should be negative 60 minus positive 60. Y'all are right, yeah. Right, so that makes sense because a negative 120 would cause influx, right, into the cell because you have a positive sodium and a negative driving force. Sorry about that. I wanted to add this for clarity and that confused y'all, but I'll fix it on the when I correct it on the, and I'll put it on the Scrubs page. Right, so you get a positive sodium and a negative driving force, so you would expect influx. Okay.
So just clarify why it's influx again.
Okay, because if you look, remember that the trick is opposites attract. So you have positive sodium, that's your cation, and you have a negative driving force. If we look at the graph right here, we look at this graph right here, driving force is positive. I'm sorry, the driving force is negative and you have a cation, right? Sodium's a cation. So it's going to go into the cell. So saying negative 120 is this thing is saying positive 120 of influx. So be careful how they word it on the test, because that's actually the trick to this question, is that you don't see any negative values right here, right? And that's because once you determine whether it's influx or efflux, you basically take that is acting as your positive or negative sign, right? So yeah, that was like a next level aspect to this check. I think it was Dr. Bandelow's question. Okay, y'all had questions about this? What? Oh, Lindsey, she walked off. Okay, I'll just explain it one more time. So remember, sodium is outside the cell. So once these channels open, sodium's going to rush in. That's point B. What were the questions, Lindsey? And then potassium's going to.
I send them to you.
Oh Lord.
What's that?
Oh goodness. All right, hold on.
I took a picture so you could just see them, so I didn't have to read them out loud for you.
The rectifier channels, I think those are limited to. I don't think you need to worry about that right now. That's more when you get to cardio. That is tricky. I know there was one about the peak. It's my understanding at this point the sodium channels are starting to close. So at point B, the sodium flux would be higher than at the peak. Okay, I didn't want to get into that too much because y'all do it later and stuff. But at this point, you're starting to slow it down. And technically, you do have more sodium at point B than you do here. So you're going to have an increased driving force. But don't get caught up with that right now.
Gunnar says hi to everybody. Okay, now he's leaving.
E is at resting potential. So E is back to where all the gates are closed, right? So you're basically right here is the same thing as right here. Option D. So D is that absolute refractory period. So at this point, these sodium channels can't open up, right? So you have to wait till it gets back to this point until you can actually open sodium channels again. It's really difficult because you get into this in so much more detail, and I really don't want to go too far because y'all are literally just starting. But I know a lot of people have a more extensive background. But let's just keep it for what you need to know right now. So yeah, all right. So just one more time so we have this right. we would say -60 is your membrane voltage. What was E again? Equilibrium potential. So -60 minus 60 would be -120, right? So saying a positive 120 of influx is like saying the same thing as -120, okay? Why is it influx? Because sodium is positive right here, and the driving force was negative, so it's influx. Okay, just one of those things you kind of have to sit with. I would go ahead and memorize these values here, just because they will help you. They will help you with your with these problems. You won't have to look them up and stuff. Okay. Okay, that should be good. All right, let's try that. Right, so a question, if it was potassium, right? So potassium is also positive, but you would probably get a positive driving force too, right? Opposed to that negative. So the question was in the last question, what if it was a positive driving force and a positive potassium, then this would be efflux, right? Because they're the same, so they don't attract efflux. Right, so potassium would be going out of the cell. When in doubt, just like bring your brain back to like where sodium is and where potassium is, because I honestly thought, I was like, I hope this works term one. And I would, every question they would do, I was like, are they trying to trick us and put in like a ton of sodium in the cell? And they never did. It was always like what it should have been. So, but if you like the trick that opposites attract, that works too. Let me just elaborate a little bit, because I remember this topic being a little difficult. So remember that we're putting everything in a pot, right? So by doing this, what you'll find is that you get this equilibrium potential around -60, okay? Right? And the point is that once you put everything in the pot, you have, I'm sorry, that's not, it's not potassium. That is, so sodium outside, you have chloride outside, you have calcium outside, right? And you have all this potassium inside. Now you can ask yourself, what's the most important player here, right? Who's doing the most? Who's doing the most? And the answer is potassium, right? Because it's holding it close to its equilibrium potential. Chloride's a little weird one because it's outside the cell, but when you think of sodium versus potassium, those are our main players. And the point is that if you alter this, say you put a lot of sodium outside the cell. I don't want to go too far, but this was an important topic, and y'all may elaborate on it a little bit next week. So if you put potassium outside the cell, you're going to bring this equilibrium potential closer up, right? Or if you add potassium inside the cell, you're going to bring it down here, because potassium is such an important player in keeping this membrane potential. So when you'll see patients that have hyperkalemia or hyperpotassium, right, you'll see that this value, because what happens is they're getting a lot of potassium outside the cell. So this value comes closer to here. So actually they end up getting arrhythmias, right? So this threshold to fire, this action potential to fire, is closer to threshold. So it fires more rapidly, right? They start twitching, their arms will twitch, or they'll get heart palpitations or an arrhythmia, which is like an irregular beat. But the point is, if under normal conditions, you want to hold it at about -60. It may be, I think maybe -60. No, it is -60. Sorry. So you want to hold it there, and that there's a lot of factors that go into it, like how many potassium channels you have, how many sodium channels, what's the percentage in and out. But under general conditions, this is what you want to stay at. So keep in mind, and they use potassium as the primary example with hyper or hypokalemia, which means increase or decrease potassium, just because by doing that, you get these variances. Now imagine if you had a lot of potassium inside the cell, right? Or decreased potassium outside. it would be harder to fire an action potential, right? So they start to get weak. Their hands get weak because it takes more energy to actually fire an action potential. Okay, so y'all may get into that a little bit more detail, but if you were asking why are we going through this in a clinical aspect, that's the thing, because when you patients have increased or decreased potassium in their body, it does affect this action potential or this rate of firing. Okay, we looked at this one. So this is another one you get into in much more detail. This syncytial trophoblast, they actually secrete beta HCG. That's what a pregnancy test is. It picks that up. So you'll get into this in much more detail, but it was in your slides, so we wanted to bring it up. Embryology is one of those things that everybody or not many people enjoy just because it's like a foreign language. But this is a nice table that I put in here. By all means, you want to learn neurocrest cell. There's a joke, like if you don't know the answer, just always go with neurocrest cell, just because it's like random and stuff. But this is, again, first week, just introducing you to this table. It'll come back again and again, so it's there for you. All right, let's do some histology. And after this, I will go fix the slide with the math problem, and I will add Lindsey's question set to the end. So it'll be reposted on Scrubs with everything corrected. All right, so what are we looking at here? Does anybody know? We can do this interactively. What is this?
Is that a hemidesmosome?
Right, hemi meaning half, right? So what does it connect to? What is this down here?
The basal membrane?
Right, so it's holding on to the bottom.
Or,
yeah, exactly, same thing. You can use that interchangeably. Right, so it's half. So you could see a hemidesmosome, So a hemidesmosome is gonna be just this half, right? Or if I draw it correctly like it is, it's kind of holding on to the basement part.
So
Whereas
if it was like a regular demizone, then there would be like another side to it that looks exactly the same.
Just like this, right? So the desmosome is going to connect two cells like that, right? This hemidesmosome, I like this picture better, is holding it onto the basement membrane. That's like kind of hooking onto it, basement membrane. So you can see that here. For right now, you really don't need to get too far into the disease processes, but I wanted to break it down here. So this will help you remember it. So the disease, so if these adhesion molecules or these proteins that hold the cell together, hold the cell to the basement membrane, if they're defective, you get this these bulli or these large blister formation. So I remember this is bullous pemphigoid. Y'all might have mentioned this in small group. It sounds like below, and remember hemidesmosomes are below. So this hemidesmosome is just half holding it on. So what you'll see, this blister formation is very up and down, right? Because the problem is with these. So these blisters are hard to pop because the problem's down here, not with the sides. What you'll see with the desmosomes and pemphigus vulgaris is these blisters are more rounded like this. And that's because the problem's here, and these are easy to pop, right? Because it's these walls that are holding the sides. So just keep that in mind. That'll help you remember. But if you get these words mixed up like everybody does, bullous sounds like below. So that's the hemidesmosomes. So they will ask you questions such as, well, was the blister easy to rupture? Or what, you can look at the shape formation. Just look it up online. It's one of those things that's interesting for people want to go into derm. Okay, and this is more of the same. Look, here's an example of a desmosome. It kind of has this train track formation, right? But you can see those little proteins that are sticking out the side, those extensions. And this is from first aid. So you see it's very dense and it's not a lot of details, but it will tell you what you need to know. And there's that little, see, bullous sounds like below, right? And knowing, I know y'all have a slide on it, like knowing what proteins go with each are going to be important. So like integrins are something very specific to hemidesmosome. Connexins are what the complexes that make these pores for the gap junctions. Cadherins you could find in the macula adherens and the zona adherens. So the way, this is a very nerdy way to do it, but so I feel like these occludins right here, that's kind of like glue, right? It's gluing stuff together and it doesn't let stuff pass through. These zona adherens, they're kind of like a tie wrap, right? So stuff could get through, but it kind of holds, it just holds it together. And then the desmosomes are more like a spot weld. Like if you're welding and you use electricity, right? Or whatever you use to weld, but it's like a spot weld. So it's really hard. I don't know why. It was a late night and I was just thinking about it and it's really nerdy, so don't judge me. And then hemidesmosomes are again at the base, right? So it's holding on. So that's kind of how I think of it functionally, but if that helps you, then go for it. All right, try this one. All right, so this is a tricky one. I always have to look this up for whatever reason. This is holocrine secretion. So when you think of holocrine, you're thinking of sebaceous glands or pimples. So merocrine is going to be like sweat glands. Those are the two they'll probably ask you about. Apocrine is like pheromones. Nobody talks about that. And then autocrine is just the method that it works with. So if you see here, merocrine again is like sweat, holocrine's like a pimple or sebaceous gland, and you don't need to worry about that. And then endocrine glands means that whatever the product is going into the bloodstream. Okay. Paracrine signaling is para is kind of like next to, right? To the cell next to it, and autocrine is cell to yourself, right? So that should help you work that out. Again, this is from first aid as well, I believe. No, maybe it's from your lecture. Oh, lectures. There you go. Never mind. All right, let's do some of this. This will be merocrine is, what did I say? That's sweat glands. Yeah. Okay, so we're gonna work through this, but this will definitely be on your test. Did y'all have Dr. Martin yet? Yeah, he's cool, dude. All right, if you want to do this on paper or whatever, you're more than welcome to. I'll give y'all a minute. What about Dr. Impaja? Did y'all have her yet? Yeah, she's my favorite. She's the best.
Hey, Brady, what
Yeah.
is the 3' to 5' orientation of the answers?
Okay, this is why I did this, because you, regardless if they tell you, the answers are always 5' to 3'. Always, you always read 5' to 3'. And this is probably how it'll be set up on the test. Okay, let's try to work this out. It was D, remember we did ask about it has to be RNA, right? So we have to go. So the first thing you want to ask yourself, well, which one's the sense strand? That should be the first one, right? And then the complementary strand, also known as the anti-sense strand, also known as the template strand. Why is it the template strand? Because it's the template for the RNA, okay? So the complementary strand, so you take your sense strand, okay? And then you're gonna go, remember, I wrote this correctly in the right orientation, but remember, as you do it, it's gonna be 5' and 3' over here, right? So it'll be CG, CGAATT, right? But then you can see here, I wrote it correctly, right? You always have to write it 5' to 3'. So just get in the habit of doing it. Okay, so this complementary strand is going to be our template, our RNA template. So I just brought that down here, right? And then now from this, we need to make our RNA, right? So we're going to, again, we have to write it this way, right? So however you want to do it, backwards, forwards, and always we're switching wherever a T would be, you're switching it for a U. And then remember, the answer is always going to be 5' to 3. So this one just takes practice. You got to work at it, but they'll always be 5' to 3. So that's what I wanted to illustrate there. We good? We good. All right. Let's try this one. Okay, let's see. Right, so C's are 20. So remember, this is complementary, right? So C's have to attach to G's, right? So if they're, and we use, what do we use? Uracil. Okay, so we're going to switch it over. So if you have 20% C's in the DNA strand, you have to have 20% G's, correct? Right? It's because they always attach to each other. So for those, so that's 40%. So that means the A's for DNA, the A's and the T's have to make up 60%. Right? Which means A is going to be 30, T is going to be 30, right? And we know for RNA, T goes to U. So U should be 30. Cool, right? So do this even in your head. The C's and G's are going to make up 40. So the A's and T's or A's and U's are going to make up 60. Split them in half, get 30. This will be a test. Playing this cytosine, sorry. Yeah, the C's, yes, sorry. I'll fix that too. Right, okay, and so this is how it works out, right? So C's are 20, G's are 20, and then you split the A's and T's. So, and the U's will be 30. All right, this is super high yield as well. So let's try this one. Okay. So you're going to want to keep these straight in your head. We're talking about transcription. So is that euchromatin or heterochromatin? U, right? Yeah, euchromatin is what you want to be transcribed. Hetero is silenced, right? So we're looking for euchromatin. So methylation always silences genes. Okay, so you want the DNA to be demethylated. No, I'm sorry, that's not, it should be C actually. Let me see. Whoops. Yeah, sorry, C, yeah. So it should be C, right? So you always want the DNA to be demethylated and histones to be acetylated. So if the histones are deacetylated, right? Deacetylated, they're gonna be charged, positively charged. If they're deacetylated, they can wrap up the negatively charged DNA. Okay, so by acetylating the histones, you're taking away the charge, so it won't bind the DNA. The way I remember it is they're opposites, demethylation and acetylation. If you want silent genes, you get methylation and deacetylation, right? So positive one, negative the other. So, right, again, methylation is always going to silence the gene transcription, and then this kind of explains the acetylation. But basically, if it's deacetylated, it has a positive charge on it, which means it could wrap up the negative DNA. Okay, if it's acetylated, as you see here, it's not charged, so it won't bind the DNA. So euchromatin, demethylation, acetylation. Heterochromatin, methylation, deacetylation. So one of them has to have the D on it, DE, right? As for DNMT and maybe just a little definition on it. I don't know if they'd really test you on it. It's not super high yield, but just know that it all works together to methylate the DNA, right? So it's a process to bind everything. I can't seem to, I don't really remember them asking a question on it, but I don't want to tell you not to. So I'd just say it's low yield. Okay, yeah, and this is what I was saying. So they're opposites, right? So you have to have the D on one. So if you just remember DNA methylation is going to silence it, the D has to be on the other one. I know sometimes you make up mnemonics or whatever works for you and it doesn't make sense to other people, but that works for me, right? The D has to be on one. So keep that in mind. Let's try this one. All right, very good. So, so these both RB and P53 are cell cycle. They're at the G1 checkpoint. So they're going to stop everything from being replicated or synthesized, right? So you have to remember that if they're activated, they're like a stop sign, right? If they're activated, they're going to stop transcription. Okay, it's a cell cycle checkpoint. So if the checkpoint is activated, you're not going to transcribe. What you'll find later on is P53 is actually problematic in almost 50% of cancers, right? So this is because if you can't activate P53 or stop gene transcription, the cell's going to keep making DNA, right? And that's tumor formation. So P53 is super important. Retinoblastoma there is a childhood retinoblastoma cancer, but y'all will get into that later. Just remember that they're part of this cell cycle regulation. So yeah, Lindsey, we did have to remember this was important, right? This was like a slide. Yeah, so you need to remember like what goes with what. It's like one of those silly things they just make you memorize. So like the G1 checkpoint has cyclin D, which goes with CDK4 and 6. Just one of those silly things. Oh, which does bring something up. If you look on the Scrubs drive in the additional resources, what I do right prior to the test, a few days prior, I write shorthand notes that it's like the stuff I need to burn into my brain. That's like strictly memorization. So if you want to see what I felt was like super important, this was one of those things. I had to put like G1, D, 4, 6. So you can go on the drive and you could find it. It's just a few pages for each test. And just the things that were just strictly memorization that were hard for me to keep up with. Okay, again, more of the same. Oh, this was it. This is a better representation of the same thing, but better representation. So just make sure you have these and know which goes with what. Yes, we will upload these videos for sure. Yeah, so you can go back and view them. All right, cystic fibrosis.
This is my dog right now. He's mad because he wouldn't come say hi to you guys though, but.
We'll meet my dog later because I'm jealous now when Lindsey does her stuff. All right, so cystic fibrosis is what kind of inheritance pattern? Y'all are going to do this a lot next week, but I wanted to touch on it. Autosomal recessive, correct, right? So if this is foreign to you, just know you're going to get into it next week. Actually, I don't need to draw this because it's on the next slide. So it's going to be 67%, and I'll explain why in a second. Okay, so cystic fibrosis is autosomal recessive. But remember, the question asked, what is the chances of her sister being a carrier? Now, we have two options for a carrier state here, right? We know one of the sisters has it. We know that it's autosomal recessive. So there are two options. Right? So your first thought may be, well, it's a 50% chance. But when we do these, and Dr. Sobring will harp on this, if you're asking if the sister's a carrier, you can assume she does not have the disease, okay? Unless they say it's in utero. But you can assume that the sister's in the office, she doesn't have cystic fibrosis. So we're saying one child has it, the other child does not. What are the chances the other child is a carrier? So that's a 2/3 chance, okay, for an autosomal recessive. So 67%, okay? And y'all will get into this a lot. These get more difficult, but
I just want to make a note. Somebody asked why you don't need to know the parents in this situation. The reason being, since this is autosomal recessive, for the child to even have CF, both parents have to be heterozygous or homozygous recessive. And so if both parents are unaffected and they have a child that is affected, they have to be carriers, 100% carriers. And so you don't actually need to explicitly be told mom is this, dad is this, because if they're both unaffected and if the child that's affected and the disease is autosomal recessive, you know they're both heterozygous.
And you could see that here in this example. So it's likely, I mean, one could actually have cystic fibrosis, but like Lindsey was saying, they're both heterozygous for it. So that first child that ended up with cystic fibrosis, it was a 1/4 chance, right, that they would get it. That was the one that actually did end up with the disease, right, because both parents are carriers. But yeah, like I said, y'all will get into that a lot more next week and FTM2 as well. So this is kind of one of those tables if you want to break it down. Don't worry about this too much now. Next week, y'all will get into it. All right. Dr. Sobring loves these, so. Oh, wait, y'all haven't had Dr. Sobring yet? Oh, so this must be from one of his DLAs, but yeah, next week, y'all will love him too. He's a good teacher, he's a good guy.
Y'all love Sobering.
All right, so you might ask yourself, what is this gain of function thing? So there are two gain of function diseases you need to know right now. one of which is achondroplasia, so short stature. And you say, well, why is that gain of function? They lost height, it should be loss of function, right? But there is a protein that actually closes the growth plates, and that's what they're referring to. So for right now, what you need to remember is there are two gain of function diseases. Huntington's disease, it's a neurologic disease. It causes like it's like dance, like flailing movements, kind of like Parkinson's, but different. So the novel function is like these rhythmic movements that are really uncontrollable. And then achondroplasia is too much of the normal function, which closes the plates. But I wanted to point this out because this is testable. It'll come up. So those are the two you need to know. All right. Let's get into some drugs. There are not too many drugs you need to know for FTM1, but these are the kind of questions you'll get. CF, yeah, okay, I'll get to that, yeah. Okay, so this may seem difficult, but if once you memorize and have a solid definition for each of the drugs you're doing right now, you'll be fine. But these drugs are incorporated into FTM because it has to do with DNA replication. So your first question is, what's the first line treatment for herpes, right? Acyclovir. So this is what it uses. And there is a difference between using the viral kinase versus the host kinase. What's cool about this is that if you don't have herpes and you take it, it won't be activated because the viral kinase add a phosphate group. That's what a kinase does. So viral kinase has to activate the medication. It works out good because if you have it, it'll work. If not, it doesn't affect you. So, but I went ahead and put these here so you can see like what kind of questions they can ask. So if you have a solid definition for the different drugs, what they do, the mechanism of action, you should be good to go with these sort of questions. And obviously what disease process they treat. Just a quick one to keep these topo 1 and topo 2 different. It's E-tuposide 2, right? 2 for 2, E-tuposide, right? DNA gyrase, y'all will get into that too. Cipro, that's a very common one, common medication that's used. And I can point out here, what's the whole idea here? What is this lack of 3' OH? Well, each amino acid or each base that has to bind has to have a 3' or end of the chain OH group. So to bind the next base, right? So if you what these medications do, they look just like the base, like ACG or T, right? They look just like it, except they don't have this little hand that's sticking out saying, you know, let me grab onto the next base, right? This 3' OH. So it's incorporated into the DNA strand, but then it terminates it because nothing can bind to it. So they literally look just like the base, except they don't have that OH to bind the next base. So that's why they work. And then, yeah, y'all learned about this. Topoisomerase is on the ends. Okay, but I just wanted to point out this was a good way of learning the medications in question format. All right, let's try one of these. This is post-transcriptional modification. All right, we got some good answers here. So it ends up being C. That's the correct answer. So the ideal scenario is you want to splice out the introns. There's new studies that we thought introns originally were this junk DNA that was incorporated through evolution, but there is evidence to say now that the data in the introns is actually relevant. So this is an ongoing thing in medicine. But the idea is it should look like A, right? You're supposed to splice out these introns and just have exons. So why is this intron here? Let's see if okay, so first off, just the intron site is, or the donor site is a GU and the acceptor site is an AG. So you would expect a GU there and an AG there, telling it where to snip it. All right, so this is my rule, this works for me. You always go from first available donor to first available acceptor. If you remember that, you'll always get these right. So if you walk along, you go from first available donor, you cut here, to first available acceptor, cut here. Intron 1's out, perfect. Now, what happened in the situation we were just looking at is that this donor site does not work. Okay. So use the rule, go from first available donor to first available acceptor. Walk along, nope, can't use that. We're still looking for first available donor, okay? That's not a donor. Okay, keep going. Okay, here's one, cut here. Now you go to first available acceptor. Okay, go here and cut here. So intron 2 is gonna be out, but you can see we left intron 1 in, okay? So that's how I do it. Let's do it this way. Let's say they take this. Let's say they take this out. The slides are posted on the Scrubs Drive. You can get the you can get them there. The reason the first donor site wasn't available is just from the question we just did. It said it was mutated. Okay, so let's assume that the acceptor site is messed up. Okay, so we're going from first donor right here to first acceptor. That doesn't work. That's not an acceptor here, right? So if this acceptor site is messed up, you're gonna take all this out. Okay, hope that makes sense. Now let's try one more thing. Let's put another acceptor site, a mutation with an acceptor site here. Okay, first donor site, cut here, to first acceptor site, cut here, right? So this gets taken out. Now from this point, we have to go to first donor site. That's not one. This is one, to first acceptor site there. So what'll happen when this comes out is that you'll have a little piece of extra intron because you cut this out, but not this part. Okay, so just use this rule here and you should be good to go. All right, and then if you want to, this was from the notes, if you want to go into it, this is kind of what I just did, but if you add stuff in different places where it goes. All right, my last topic, we're going to cover everybody's favorite, mitosis and meiosis. So Sean, for your question for the donor site, that's not necessarily true. You can't, you don't want to just assume that because they could put extra donor sites in there. The question was the mutation in the donor site results in a shorter transcript. Just try to use the rule that I do, and it works out any possible way they could give it to you. All right, so let's take a look at this. So, and again, you'll learn this a lot later, spermatogenesis. So the sperm have to be haploid. So you're gonna have the 23. So after meiosis 2, they split from meiosis 1, they split to 2, meiosis 2, they split to 4. So they're gonna be haploid. So let's look at this real quick. Make sure you keep the N's and the D's separate, right? So for here, chromosome number, you have 2N, that's 2 colors, right? That's representing the colors. You have two types of chromosomes. So first in the cell, they have to replicate. So the blue replicated and the red replicated, okay? So now after you have this duplication, you have 2 in, right? 1, 2, but of that, you have 4 chromosomes, 4 copies, 4D, 3, 4, right? Now meiosis 1, you're gonna split them in half, right? So you have, in each of these, you have 1, right? 1 color. But in each of these, you have 2 copies, okay? Then meiosis 2, you're splitting them into haploid, right? This is where the sperm is, or yeah, you can see that here. And then once you do that, this is after fertilization. So you're gonna add mom to it, or dad, and you're gonna get the green in here, right? So then you're back to a normal cell, and that'll be your zygote. Okay, so the questions they like to ask, which trips people up, is this non-disjunction. So did non-disjunction happen at meiosis 1 or meiosis 2? Well, you can see here, if non-disjunction happened at 1, all 4 will be on one side, right? So they should have split in half, but you'll have 4, you'll have 2 in, 4D in one of these and nothing in the other. So this is how they'll turn up. And I'll give you examples in just a second. If non-disjunction 2 happens, it's at meiosis 2. So you see that they didn't separate here, and this is normal. So what ends up happening is you'll have a trisomy. So like Down syndrome, okay? So these are the questions they can ask. Now, this isn't 100% definitive. Like a lot of things in medicine, there are exceptions. But if you have a non-disjunction in 1, such as Klinefelter syndrome, which y'all will learn about, these are males that have 2 X's. The trick I use, if it's a 1, then after the first X, you have 1 X and 1 Y. You skip the first one for all of this, okay? Turner syndrome, you have 1 O, okay? Now in non-disjunction 2, you have, after the first X, you have to get 2, right? So 2 X's or 2 Ys. So they'll probably ask you about these. These are more common. Like I said, technically Turners can be over here. But it's one of those things, if you're tripped up on the exam and they ask you about Klinefelters, you're like, well, it has 1 X and 1 Y after, so it's 1. If you like that, you can use it. If not, yeah, whatever works for you. It's just, I know meiosis and mitosis are a tricky thing. Okay, again, you could find my slides. I'll update them with this few corrections there. But if y'all want to, you want to do a 5-minute break, Lindsey, and then we'll do questions. How long did that take? Yeah, it took a while.
You guys want a 5-minute break? We're actually like doing good on time comparatively, honestly. Okay.
Keep going.
We have 1 vote for keep going. Do y'all like that?
We will question. Yeah, we're not going to do this next week just because our test is on Monday, that following Monday. So we're going to be in a hole that you won't be able to find us.
Just so you know, Charlie is sound asleep at my feet, and it's so cute.
Okay, so
we'll try to go through the questions fairly quickly.
All right.
So we're not gonna spend like a huge amount of time. Thanks for the good luck. Ooh, okay. Zoom, you need to chill. I don't approve of what you're doing right now.
Hi, Lindsey.
No, stop it. Okay, you gonna chill now? Okay.
Hi, Lindsey.
Hi.
I have a question about the 2/3. Is the question asking the percentage of, in terms of like carrier without having the disease, or just carrier alone?
A carrier
Lindsey.
is by definition a heterozygote. That is the definition of a carrier. So when you get a question that is asking about that specific one, was asking the chances of another child being a carrier. And so you have to eliminate the square in the Punnett square that is homozygous recessive, because homozygous recessive would have the disease. So that by definition is not a carrier. They are affected with a disease. And so that leaves 3 squares in the Punnett square. So you can either be heterozygous, I'll actually, if I can find, ooh, my stylus right here.
So you assume, so the child's born already, like this child's
Yeah.
coming in, the child's like 5 years old. You can look at the child and say, they definitely don't have cystic fibrosis, but what are the chances? Since her sister does have cystic fibrosis, what are the chances that this kid does have it? So
Yeah.
you would eliminate that one part of the Punnett square that says they definitely have it. Now it is different if they're saying the parents are expecting another child.
Yeah.
So you can't necessarily rule out the fact that that the child has the disease, but this 2/3 rule is going to come in effect next week and stuff with Dr. Sobering. So it's just good to be aware of it.
So if
Okay.
this was an older child and you know they didn't have the disease, then you know they're not homozygous recessive. So then the question asks, what is the chance of them being a carrier? A carrier would be a heterozygote. That's the definition of being a carrier. And so it's 2 out of 3, 2/3, which is 67%. Does that make sense?
Got it. Thank
Cool.
you.
Yeah. This is a good place to interject this. Make sure you read the questions very carefully, and make sure you're answering the question that they're asking and not the question you think that they're asking, because a lot of times you'll go through this long vignette and by the end of it, you have an idea of what they might be asking you, but then the last sentence might change what you think they're expecting of you. So make sure that you don't just glance through these questions. You really want to take the time to read them. So, okay, so we're gonna go through these questions. I'm gonna give you guys about 30 to 45 seconds on each. Remember, private message my Brady. Private, oh my God, I can't talk.
Hey,
Private
I'm not an
message
object.
Brady or myself with your answer choice, like you guys have been doing. Yeah, Brady, my Brady. Some of this is going to be kind of a repeat from what Brady did, but what that should say to you is that if 2 people are focusing on it, it's probably really important. Everything is going to be uploaded to both of our pages after this. So you will have access to all of the resources.
You'll be able to click the same link you clicked before, except it'll just be corrected. So just give it, by the time the recording's posted, that'll be posted as well. So just give me a little while because it has to upload and all that nonsense.
So for these questions, you want single best answer choice. That's how SGU does their questions. You're not going to have pick more than one or something like that. You changed positions. Okay, so there seems to be a consensus. You guys are right. Cholesterol, the best answer is stabilizing the membrane, because if it's too hot, it gets too fluid. And so cholesterol is there to make sure it doesn't get too fluid. The converse is true. If it gets too cold, cholesterol will make sure that there's enough separation to allow for fluidity.
So temperature dependent, they're opposite, right? So
Yeah.
cholesterol is going to help regulate it. So if you're cold, like frozen, cholesterol is going to let it move. If you're hot and you're moving too much, cholesterol is going to stiffen it. But at body temperature, it will stiffen the membrane, which is probably what they'll ask.
Yeah. Remember, if you guys have questions, you might want to send them to Brady. You might be able to touch on them. Oh, you guys are getting this good. I have a trick for you if you haven't already seen the trick.
Somebody knows it already.
Oh, yeah. Okay. So what is our trick? You can say it out loud if you want. The trick is 2 steps forward, 1 step back. So interrograde is forward, 2 steps forward, cop 2. Retrograde is backwards, 1 step back. And so that would be cop 1. You do need to know the difference between there's terminology that they use for the Goldie. I can't remember what it is off the top of my head, but you do need to know that terminology because they can throw that at you. Yes, CG. Thank you guys. Cis
Oh,
space.
cis and trans. Yeah.
Thank you guys. This one is super high yield. And it's also an easy question if you understand it. I'm pretty sure they have like 3 or 4 slides that talk about this particular thing. Ooh, we're kind of getting a spread. I like that. Okay. So we're talking about actin polymerization. And when we are a structure that is for the main side of actin polymerization, that's actually lamellipodia. And so there is a slide in your lecture that draws it out really well, and it labels the lamellipodia. The lamellipodia is that structure. It looks like it kind of extends forward in front of the cell, and that structure is facilitated by positive actin polymerization, and that structure is called the lamellipodia. But they love
It reminds me of like fingers, like sticking out, and it kind of grabs and pulls back towards you. So that's how it kind of moves forward. It like grabs on and pulls backwards.
Yeah. This one I didn't even try to make a vignette out of, but it's an important concept. Yeah, you guys are getting this. Oh, congratulations. New family member. Okay, you guys got this. It's childbirth, but real quick, you can unmute yourself. What is the definition of positive feedback, and how do you differentiate that from negative feedback?
Positive feedback has a definite endpoint, so something has to exit for it to stop, because it keeps on increasing the whole thing.
Yeah, it builds and builds and builds. So the response is amplified. Thank you, Mitchell. That's a really good way of explaining it. So whatever is being produced is causing more of its production. So it just keeps saying, okay, I need more, I need more, I need more, I need more, until there's a finite point of some kind of release. And childbirth is a really good thing, a really good example of that. Whereas negative feedback is basically, okay, we have enough, so you can stop. That's a really simple way of putting negative feedback. Yeah, returning something back to normal. Exactly.
But typically the body's going to use a negative feedback system. So the end products are going to feed back to whatever's stimulating it and saying we have enough of it. Positive feedback is one of those differentials.
The term twos are learning a lot about negative feedback right now, because too much of a good thing is a really bad thing when it comes to endocrine system. Okay, we have a mix between 2 answer choices. but I think the majority of us are getting this right. So it is absence of DPPC, dipalmitoyl phosphatidylcholine. I have a lot of people that are choosing A. It's not A because we're at 20 weeks. And so at 20 weeks, you have complete development of the lung. And so you can deliver a child at past 20 weeks with the expectation that you do have that organ development there. Prior to 20 weeks, you could say an underdeveloped lung, but I did specify 20 weeks. But no, it's the surfactant. And so, and I mean, this can happen up until birth. This is what decreases the surface tension in the alveoli so that they don't collapse. You will learn a lot about this as you move forward. For FTM1, you need to know the LS ratio. You need to know what DPPC is. You need to know the term surfactant. So what's on that slide is what you need to know for FTM1, and you'll get it more hardcore in CPR2.
Yeah, so the LS ratio, lectin to sphingomyelin ratio, would be less than 2. That would have been a correct answer.
Yeah.
And the reason you can say that the lungs are developed, so a lot of times if you're expecting a premature child, they could give the mother corticosteroids to increase the surfactant production, which means that you can have a child at 20 weeks. You just have to have that surfactant artificially provided.
Yeah, but in CPR2, you are also going to learn that at 20 weeks, you get the type 2 pneumocytes that develop the surfactant. I actually think it mentions that in your slides. I was going through your slides, and it actually mentions the type 2 pneumocytes. But you'll learn a lot about that in CPR2. LS ratios for amniotic fluid, yes. You getting
This is Phoebe.
Did you wake her up, or did she?
Yeah, she's always sleeping. She wanted to say hi too. So
Hey, Phoebe.
we have mascots for our group. So yeah.
Yes, they will be harder than this. I only had a. Okay, so the answer to this is a reflection coefficient of 0. So we're saying what is most likely completely permeable. So you need to know the definitions of these questions. Now I am going to make a note. They probably won't test this. They are going to expect you to know what these things are, use this terminology in the clinical vignette to be able to answer a question, for example, about osmolarity and tonicity, because this is going to determine if something is going to cross the membrane. So reflection coefficient, all you need to know is 0 or 1. 0 is going to pass, 1 is not. Permeability coefficient, it's going to be 0, 1, and then like
They're exact opposites.
Yeah.
Can it
They're
go
the
through it?
exact
Can it
opposite.
reflect? Yeah.
But permeability coefficient that is not 0 or 1 is going to be slightly permeable. It's not completely permeable. And I did specify completely permeable in this question. So if we're talking about complete permeability, it is reflection coefficient of 0. Again, I want to reiterate, these are terms you need to know to answer questions, but this probably won't be something that they will directly test you on. You're just going to need to know what those terms mean to answer questions. This concept is easy once you understand it, and they're probably going to have one of these questions on each one of your exams in term 1, just to let you guys know.
Do you want me to do it out for him?
Oh, I can do it. I actually have an explanation slide.
Okay. All right.
Okay. So first off, we're saying the osmolarity and tonicity of a red blood cell placed into a solution. A red blood cell, unless otherwise specified, you can assume is 300. So they usually say 280 to 300, but 300 if it's not specified as something else. So I'm going to go ahead and annotate this, and then I'm going to show you the slide. So we have a red blood cell, which you can assume is 300, and then you have 100 NaCl millimolar. So if you have millimolar, it needs to be in milliosmoles. So how do we convert 100 millimolar NaCl? Well, all you do is multiply this number by however many elements are here. So sodium and chloride, that's 2, meaning you have 200 milliosmoles of sodium chloride in this solution. You also have 400 milliosmoles of urea. Now, you'll notice I did not put a reflection coefficient in here. Urea is one of those that is known to be completely permeable, so it's a reflection coefficient of 0, whereas NaCl known to have a reflection coefficient of 1, and so they will probably give you those values. I put in here because these are direct from your notes, and so I was hoping you just knew that. So if we're talking about osmolarity, this is the moment the red blood cell is dropped into the solution. So you add up everything, it's 600 milliosmoles, and so this is hyperosmotic. So we're going to eliminate B and C. Now, after time, so hypotonic, this is once it has reached equilibrium. And since urea has a reflection coefficient of 0 and it is completely permeable across this membrane, that means once urea reaches equilibrium, this number is now negligible, or not the 600, the 400 is kind of now negligible, because, I mean, you can assume that it's equilibrated, that's a word, to 200 on one side and 200 on the other. But since it's even, it's pretty much negligible. So all we care about now is the NaCl, which is 200 milliosmoles, again, 300. So this is lower, so that's hypotonic. And so the answer is going to be A. For you guys. Oh, come on. A. So you're always talking about the solution, if you're asking the question, because the red blood cell, because water is going to move in the direction of a higher tonicity. And so the water is going to move from the red blood cell. And so the solution is kind of what dictates the water movement in and out of the cell. And so at first, the water, if this is hypertonic, and water is going to want to go and kind of dilute that, or hyperosmotic, it wants to dilute that out, the cell is going to shrink because water is leaving the cell because it wants to equilibrate the solute concentrations. Now, once you have urea that equilibrates, the solution is hypertonic, and so water is actually going to go into the cell is going to swell.
Would it be correct to say that we're looking at non-penetrating substances only for tonicity?
Yes. You're absolutely correct.
I had a question. So when this says in the question, it says that tonicity of an RBC. So are we looking at the tonicity of the red blood cell compared to the water, or the water compared to the red blood cell?
Oh, the solution compared to the red blood cell. I apologize.
Okay. Yeah, because that way the answer will be the opposite, right?
Yeah, it would flip. I apologize for that confusion in the verbiage of the question, but it will be very evident on a test question.
Just in general, typically you're talking of extracellular fluid. Even if they talk about increased potassium, like hyperkalemia, those measurements are always extracellular. So
yes.
Unless they tell you otherwise, you're assuming we're talking about the external environment.
Yes, that is very true. So I made an assumption there and I apologize for that, but this is what you need to know: definitions, osmolarity, tonicity. We just went through this together. So this slide will be released to you when we release the questions and answers, but this is exactly what I just did, annotating the slide. So are there any more questions on here? Okay, let's go to the next. Yeah, you have a calculator on ExamSoft. It's not as hard as you think it's going to be. There are growing pains every time you figure out that you can't use a whiteboard or scratch paper, but it isn't actually as hard as you think it's going to be. I know that's kind of a cop-out answer, but like Brady and I were actually on the island when we had to transition, and so everything about our curriculum changed literally overnight. And so you can, and it was right before like the hardest module, and then we had to go into CPR, and that's a lot of equations. And so we feel your pain. We really, really do.
It was
And
fun for 2 months, so.
Yeah, I can tell you from experience, this is not me just trying to make you guys feel good. I can tell you from experience, it is not as bad as you want to think it is. So you can do it. I believe in every single one of you guys. But okay. Also, I'm a past scribe, so a lot of my questions I start using abbreviations. So don't hesitate to ask me what any of these mean. So presents to the emergency department with blurred vision and a headache, history of type 1 diabetes mellitus, non-compliant, D-stick, which is blood sugar 340, BSG is blood sugar, now it's 109 after insulin infusion. So now what we are asking for is the GLUT transporter responsible for adipose skeletal muscle, which is GLUT4. So good job. You do need to know these. There will be maybe 2 to 3 questions on this. So GLUT1 is going to be more your brain. GLUT2 is hepatocytes and pancreatic cells. GLUT3, I always forget this one.
Neural tissue and red blood cells, I believe.
And then GLUT4 is cardiac muscle, skeletal muscle, adipose tissue. Yeah,
Insulin dependent.
GLUT4 is an insulin dependent one. So this GLUT4 is not going to be present in the absence of insulin. Why is that important? Because you don't want blood sugar going into your cells if you in a time where you have low blood sugar. And so insulin its release is stimulated in response to high blood sugar to drive the blood sugar into the cells. So if you are in a hypoglycemic state, you do not want the presence of GLUT4s to drive the blood sugar into the cells. And so it's very important that those are insulin dependent.
Lindsey, I think they changed the curriculum. Y'all didn't do apoptosis and necrosis yet, did y'all?
Oh, you didn't do this yet?
We'll just touch on this though. Yeah, that's fine. Well, this is a good point to make anyway.
So the biggest difference between, so what we're talking about here is necrosis. So it's the difference between necrosis and apoptosis. The biggest difference is organized versus disorganized cell death. Apoptosis is, of course, organized cell death. Necrosis is going to be disorganized cell death. And so A, B, and C are all going to be more organized. So aggregation of chromatin, you have the blebbing and cell shrinkage. This is all basically apoptosis signaling the cell to degrade, whereas cell swelling, you can think about it more as an inflammatory process, which is going to be a pathology, and necrosis is more a pathology. And so once you get to this, it's just organized versus disorganized. There's a whole chart in your notes, and if you memorize that chart, you'll get those questions right. Brady already did this question, but again, if I'm doing it as well, you probably need to look at this.
And
Should we
as we
also
go,
know what the other cells do as well? I don't really want to give away the answer, but if you know what I'm talking about.
Yeah.
yeah,
Cytotrophoblasts, of course, yes. do you remember these two?
They're like precursors. Like I had in my slides that germ cell line for the embryology. Not as much right now. It's what you'll find, the embryology is difficult and the teachers know that, so they keep it clinical. So if there's clinical applications for it, that's the stuff you need to memorize. And I also wanted to mention, as we go along, it is an issue like with the whiteboards, and we know that's gonna, like, it was a thing with us, it was a thing last term, but as we go along, we're gonna walk you through what we did that worked for us without the whiteboard. So we've developed tricks that we use, so definitely don't stress about that.
Yeah. But the trick here is thinking to trophoblast, S for secretion. If they talk about cell, it's C, cytoblast for cell. So I'm going to tell you guys very briefly what I do for embryo. Embryo, like Brady said, they're going to keep it very clinical. So I actually go to the end of the lecture where they talk about the clinical pathology, and I start there and I map out all of the clinical pathology. And then second step, I go through and I figure out what comes from what. And so, for example, Brady made the joke, if you don't know the answer, it's neural crest cell. That's kind of along the line. So like neural crest cell, mesoderm, all of those things, like praxial mesoderm, those are the big high yield stuff. The lower yield topics in an embryo lecture are going to be the stepwise embryology of the structure. So week 1, this, week 2, this, week 3, this. Keep it very clinical. Med students, you know, we are being trained to identify and treat pathology, and so they're going to keep it very clinical. But I do not ever go through an entire embryo lecture. Just because I go clinical and then I figure out what comes from what. And I've been successful so far. Brady can talk about how he does that too.
Same thing. Yeah, I mean, I'll read through it, but it's a lot of, it seems all made up to me. It's fictional. I don't know who made up embryology. It's like tadpoles and I don't know. So I do the clinical stuff.
I've found a lot of really good YouTube videos explaining different embryology stuff. FTM though, embryo isn't big, just to let you know. Embryo is going to get bigger when you get to MSK, but even bigger when you get into the system. So CPR and onward. I mean, MSK is a system, but it's bigger in CPR. Okay. Answer is B. So Cartaginer syndrome, I gave you guys very minimal information here, and I did this on purpose. There is one line in your notes talking about Cartaginer syndrome and primary cilia. They do like to associate Cartaginer syndrome with the primary cilia. And so there were a couple things I was expecting you to know to answer this question correctly. So I did that on purpose. But
what's the other disease? There's 2 diseases for primary cilia.
I know smokers that get bronchitis, they have deficiencies there. I would have to look it up. I know Cartaginer syndrome because they have PKD. Yeah, actually, yeah, that is true for PKD. It's a cilia problem, polycystic kidney disease. Yeah, I didn't even know y'all talked about that yet. Yeah, so that's a problem because they have a problem regulating their blood pressure. The cilia in the kidneys actually helps to regulate blood pressure. So they do have that issue. But Cartaginer syndrome, they have sinus inversus, which means all the organs are flipped. And the reason is because embryologically, the cilia actually help to orient the organs. So they're actually flipped around, and you'll see problems like guys have problems with fertility. They have respiratory problems because they can't sweep all the mucus out and stuff like that. Pretty interesting.
oh, this was our last question. So do you guys have anything else that you want us to talk about? Any questions, either content related or school related at all? How are you guys doing? I know a lot of you guys are stressed out.
Don't ask.
Your first exam is when? Which is the date?
I think it's February 5th.
Yeah.
Okay.
Oh, on a Friday?
So we will
Yeah,
not
Friday.
be holding an exam, a review next weekend, just because we have an exam on that Monday.
Yeah.
We can talk about doing another review. I'm not going to promise you guys anything just because there's a lot going on. So, I mean, we sincerely apologize about that, but we are going to try to do this as much as possible. Your term twos, they might be able to do some reviews though.
Kishore
Yeah.
said, so y'all they'll probably try to do one next weekend for y'all since we're going to be taking the test. Maybe Lindsey and I can do something like the week, like after our test is Monday, y'all's is Friday.
Yeah.
Maybe one night that week. We'll look at it and we'll let y'all know.
Yeah. We have a request to go over hyper and hypokalemia again in terms of action potential.
I have a question,
Yes, sir.
a quick question real quick before you guys do that. For the specific proteins for like post transcriptional modifications and stuff like that, like the TFD, TF2D, TF2A, do I have to know the specific proteins and what they do, or?
Yes, I would.
Yeah, a general idea. Yeah. It's tough. It's tough when you ask us questions because we want to say no, but then we don't, you know what I mean? Like, it's on, if you had a list of things to remember, it's probably on like the lower end of it, but like,
I
it's
do
probably one of
remember
those
at
things.
least 1 or 2 questions over it though.
Yeah.
I do.
So if I just know like the general idea, because they get into the specifics in the slides, you know what I mean? And if I just know like one has helicase activity,
Yeah, that's what
one
I would
does
go
this,
with.
stuff like that. Okay.
Yeah,
There are a couple that are very specific to the initiation of transcription. I would know those. The hard thing is anything on your slides are testable. Absolutely anything on your slides are testable. And sometimes a concept will only have like one question, but it's a point. It's a point. And so it's hard to say don't look at something, even if it might only be one question. So maybe I just remember studying it so heavily.
I think there's a
I
slide
did
y'all
that
have.
3
Y'all
times.
have that. It has like the definition of like TF2D,
Yeah.
and like if y'all know that, you should be good. But honestly, one of the most difficult things about med school is figuring out what you need to know. So the best advice we could give you is to keep it clinical and then go from there. All right, I'll
So
share my screen.
I've gotten this question so many times, and I want to get this point across to you. DLAs should be treated like lectures. Do not think of DLAs as anything other than just lectures. Put them in the order in which they give it to you. So each DLA has like before lecture, whatever, or after lecture, whatever. I would study it in that order. Please, 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 I beg you, do not think of them as anything other than just another lecture. If you treat them just the same as you would a lecture, you will do fine. Like we said, you have a lot of DLAs this week, and I know that's really stressful because you guys are trying to figure out your study schedules, you're trying to figure out your time management, but it does get better. You don't have the number of DLAs moving forward, but please, 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 please spend as much time on the DLAs as you do a regular lecture. You will regret it if you don't. That is what I'm going to say about that, because I've had a lot of people ask me that question.
For a recommendation for that, I just got a separate binder and then I put everything in chronological order.
Yes,
It helps
I do
me
the
keep it like organized.
I do the exact same thing. I print everything off and then I print my DLAs off, and whatever it tells me, if it says, you know, this is before lecture 1, I'm going to put it before lecture 1. If it says after lecture 10, I'm going to put it after lecture 10, because all of those DLAs are going to be associated with a topic. And even if it doesn't repeat itself in an actual lecture, it's leading up to a lecture. And so the topics are very similar and they feed off of each other. So I remember Brady telling you guys that some people will do DLAs separate from lectures, and both of us advised against doing that. And that is the reason, because these DLAs fit so nicely in the flow of information of the lectures that I feel like you would be doing yourself a disservice. Small group is a participation. I'm not going to say grade because that is not a correct way in saying that. This is what it is. You are required to attend 80% of all scheduled activities, you get a certain number of, we call them soft points, in your final grade for going to these activities. If you drop below that 80%, not only will you not get the number of soft points assigned to that category, but you can get an overall penalized grade if you drop below that 80%. It is in your syllabus. So I would read that syllabus very carefully. It does a really good job at outlining exactly how your final grade is going to be determined. Small group stuff is not on the exam. Small group does go into a lot more detail than it does in lecture. Of course, your small group stuff is going to expand upon the lecture material, but if there is any additional information in small group, I would just stick to what's in your lecture material, because that is what's going to be tested on the content exams.
And if you can, get in touch with your small group. Y'all make a group chat and do the small group in groups like Lindsey and I do. We have a group of people, we split it up. Everybody does their part, we compile it, then everybody can study it. You'll save hours doing that, okay? So you're prepped for it, but everybody has their individual assignment.
And then you make friends too.
Yeah, we know it's difficult too online. I mean, it really is. So you could speak to the term twos about that. What's that?
Are you guys talking about eSoft questions? Sorry to interrupt.
No. Like when you do your small groups, like your assignments where you have like 20 histology slides to annotate. If you do that with a group of people, you can cut down the work a lot.
Sounds good. Thank you.
Yep. Oh, you want me to try to do this real quick? We could see. So the potassium here, so it's at -60. So it takes, this is the proper amount in your body to make an action potential. So that's where we all live at, right? But let's assume that we have increased potassium outside of the cell, right? Normally it's increased inside, but if we have it outside, we're changing that driving force. We're changing that gradient. We're actually bringing it closer to this threshold. So look how much easier it is to fire an action potential. You know, this big of a difference. So what happens here is, so like in the muscles, the patients can start twitching. They can have arrhythmias or abnormal heartbeats. And that's because by having hyperkalemia, right? You're measuring it on the extracellular fluid. Hyperkalemia, you actually brought this closer to threshold. Now, the opposite can be true as well. If you have increase on the inside, or actually more often it's decreased on the outside, right? The driving force is the differential between in and out, okay? So if you have an increased gradient from in to out, you're gonna actually bring it down here. So look how much harder it is to make an action potential. It's this much of a difference. Okay, so that means these patients are going to be sluggish. They're going to be tired all the time because it takes extra energy to fire the action potential. Now, y'all are going to get into this in more detail. I'm not positive he went into this in this stringent of detail, but this is the clinical application that you'll get. So with hyperkalemia, you can get twitching and stuff just because you're firing action potentials off a lot. Okay, as for hypercalcemia, it will also, it's very similar to potassium. It'll decrease it'll decrease the threshold, so you'll fire more. I'm sorry, that's hypocalcemia, sorry. Hypocalcemia will decrease the threshold. So patients that are hypercalcemic, they usually get tetany. They'll lock up, right? Their muscles will lock up. With hypercalcemia, it would be the opposite, right? So they would tend to get weak. But when you think of hypocalcemia, they'll lock up, because if you bring it closer to threshold, the closer you are to threshold, the easier it is to knock off action potentials, right? You're firing them all the time. You want a solid gradient to make sure you're not doing too much, but you don't want it too long or too much of a gradient to where you're not firing enough.
So for calcemia, it's basically the opposite of K then.
Right, and that makes sense.
Hypocalcemia would be the same as hyper K.
Yeah, exactly. And that makes sense because calcium's primarily outside and potassium's primarily inside, right? So that would make sense that they're flipped like that. Yeah. So unfortunately for FTM, a lot of it is memorization, but the stuff I really like is like when you get to CPR and we start with the understanding stuff, because the more you can understand, the less you have to memorize. So that's what I try to do here, and Lindsey as well. We try to help you to wrap your head around it, because if you can actually understand it, that's less stuff you have to strictly memorize. It's stuff you'll tend to retain from going forward.
I'd just like to say thank you guys a lot. I mean, it's been very informative. It made me realize the things I need to look on and the things that I don't have to look on as much. And it was super helpful. I really do appreciate it.
Yeah, no worries, no worries.
Yeah, I'm glad you guys benefited from it. Don't hesitate to reach out to us if you need anything. I know there are a bunch of term twos that would be open for you guys to reach out to them as well. Also, if you ever have a question about material, don't hesitate to reach out to the professor. Sometimes it's as simple as, hey, can you clarify this for me?
We're very proud of the term twos. So y'all, they have a bunch of PLG groups. We know they're blowing up y'all class page with all of their new fancy groups. We're very proud of them. It touches our heart. It warms our heart.
Our little babies sending them out into the, we're like, I don't know how to phrase it, but we're really proud because we like giving back because the people above us were so helpful. And then, I mean, this helps us too, because, you know, we're going to be studying for step 1 sooner rather than later. Our apprentices.
They're our disciples. Don't tell them though.
Well, and you guys will get to be like the current term 2 disciples and give back to the ones coming in August. So around and around and around it goes.
There is something special about peer-to-peer learning because we're all going through this together. So we just try to pay it forward for you guys. All right. If that's all.
I just have one question, sorry.
Yeah, sure, no worries.
I don't know if you talk about this in the beginning, but for microtubules, I remember in lecture that she said that proteins come on the positive side, but then people were saying that it actually goes on the negative side because first aid said something about that. So
with the microtubules, you have kinesin and dynein, and one is going to be interrograde, one is going to be retrograde. And so the microtubules are essentially like a railroad network, like a highway system within the cell. And so dynein and kinesin are the kind of motor proteins that carry stuff from one end of the cell to the other, but kinesin does one way and dynein does the other way.
Okay.
Dynein's backwards. Yeah, dynein's always backwards. It's retrograde transport. So yeah, it depends on which way you're going. Yeah.
So I guess I'm just confused. Like she kept saying that proteins were added on the positive side.
Oh, you're talking about polymerization.
Yeah, like when it grows.
Yeah, it adds on the positive side.
Okay, on the positive side. Okay, great. Thank you.
Yeah.
And I'll post everything. It'll be posted on Scrubs DES, my Facebook page, along with Dog Mom DES. That's Lindsey's page. We'll update the slides and the recording will be posted later tonight. So I'll go ahead and stop the video, and obviously y'all are free to go. Yeah, no worries.
Thank you.